Hi everybody, Dr. Ahles here. In this short video, we're going to talk about burns, the different kinds of burns, what can cause them, and what your concerns as a medical professional would be related to burns. When we talk about a burn, there are many different things that you can be exposed to in the world that could lead to a burn. So we think a lot perhaps about radiation in the case of a sunburn, like we see over here. We may also think about burns related to heat, like if you touch a hot burner on the stove. You can also get burns though when you're exposed to high levels of electricity, or there are some chemicals that can also burn your skin. The problem with burns is that the proteins that are found inside your skin tissue become denatured. And what this word denatured means, as a reminder, is that they're no longer able to do their normal function. The function of the proteins that are found in your skin is to help build a protective layer. So if we're denaturing those proteins, that's problematic for us. Not only are the cells dying, but the protective layer on the outside of our body has now become compromised. When we think about burns, there are two groups of problems we have to consider. Problem number one, immediately following a burn, especially a very large burn, is fluid loss. When we talk about fluid loss, this is the seeping of fluid, often interstitial fluid from in between tissue cells. With that fluid, we're losing a whole lot of electrolytes like sodium or chloride. We're also losing proteins that are used to stabilize that fluid or used to perform functions. So problem number one that we have to deal with in a patient who has a critical burn, a very large burn, is addressing the fluid that they're losing through this leaky skin barrier. Problem number two, though, is protecting the patient from the environment. So bacterial infections that affect the skin itself that has been damaged, or even worse, what we call septicemia. Septicemia is when there's an infection inside the bloodstream. Once we've dealt with the immediate issue of the patient's fluid loss, then we need to start thinking long-term, how can I prevent this patient from getting an infection from this broken down protective barrier? Now, not all kinds of burns lead us to worry about fluid loss or about bacterial infections. So there's a kind of burn that most of us are probably familiar with, which is called a first-degree burn. When we talk about a first-degree burn, we've only damaged the epidermis layer of the skin. The epidermis is the outermost layer of the skin, so one layer being damaged, a first-degree burn. In a first-degree burn, this is a very typical either sunburn or I touched a hot burner kind of burn. So you'll see redness at the site of the burn. That area will swell up a little bit. It'll be painful. All of this is because the outer layer of the skin, the epidermis, has been damaged and it becomes inflamed. Now, if the damage and the inflammation goes beyond the epidermis and goes down into that upper part of the dermis, now we're talking about a second-degree burn. And when we think about second-degree burns, underline, highlight, star the word blisters. The way that you will know that you have a second-degree burn and not just a first-degree burn is the appearance of blisters. And as someone with very fair skin who burns really easily, I'm like dying inside looking at this poor patient's blisters because I have experienced this in my life and it's just awful. Now let's talk about how these blisters form. When we have damage that goes through the outermost epidermis of the skin down into the dermis of the skin, there's special connection points that attach the epidermis to the dermis. When those proteins get fried by UV radiation or by heat, the epidermis literally detaches from the dermis layer. Now we have this open space in between them, and that open space fills with fluid. So a second-degree burn has blisters because we've started to damage the dermis along with the epidermis. The most serious kind of burn we can get, though, is a third-degree burn. And when we talk about a third-degree burn, we're now talking about the entire thickness of the skin being burned. So the epidermis often is completely gone. It's been so damaged. The upper and lower parts of the dermis also going to be severely damaged. We may also, though, see burns extending down and even into that layer that's just below the skin called the hypodermis. Now, as gnarly and nasty as a third-degree burn looks, there's something important for you to know about third-degree burns. At the site where a third-degree burn happens, you actually don't feel any pain. Now, if we were in class together, I'd ask you to consider why. So here's how we'd walk through this together. If the epidermis is gone and the dermis is severely damaged, remember that neurons, my detectors, live here in the dermis. If they're burned away, I have nothing to detect that pain. Now, let's be very clear about something though. When I get a third-degree burn, I won't feel the pain at that location. But anywhere nearby that only has a second-degree burn or a first-degree burn is going to hurt really bad. And when I go to repair this burn, that's also going to be very painful as I'm literally growing new neurons. So, a third-degree burn, we burn everything from the epidermis down through the dermis, potentially even into the hypodermis. In a second-degree burn, it's just damage to the epidermis and the upper part of the dermis, causing them to separate. First-degree burn, the most common kind, just inflammation there of that outermost layer of the skin. When we're thinking about burns, we have some that we would call a critical burn. And critical burns are determined based on the size of the body that's been affected. So if you have second-degree burns, remember the blistering burns, that cover more than 25% of your body, or if you have those third-degree burns, the full thickness burn, over more than 10% of your body, either of these are situations where we would consider this a critical burn. So when we're thinking about dealing with a critical burn, we have to consider those two problems that we saw potentially affecting burn patients. Problem number one, fluid loss. The first thing we'll do for a critically burned patient is get fluids starting pumping into their system. If we don't get them fluids fast enough, their blood pressure may dip too low and they may no longer be able to push it throughout their body. Problem number two we have to deal with are those infections. So once we've stabilized the fluid volume in their body, then we need to work on preventing bacteria or viruses or fungus from getting into their body and causing an infection. One of the ways that we'll ultimately treat a patient with a critical burn is to perform a skin graft. So in a skin graft, we take a part of the patient's body that was not affected by the burn. So for example, in this patient, we'll take part of their calf skin. We'll turn that skin into kind of a meshwork that will then place over the areas where we have that third-degree burn or where we have a very severe second-degree burn. As we add back that grafted flesh, it's going to actually take hold and begin to grow in that area. So you can see for this patient, when that tissue was initially put onto their skin and their body was still getting used to it or attaching to it, versus 1 year later, where that skin has now been fully accepted into that area, and now this patient has a complete barrier at the location where they had this terrible burn. Those numbers that I tossed out for you, the 25% and the 9%, they're not just randomly determined. We use something called the rule of nines to determine about how much of your skin has been damaged in a burn. So we call it the rule of nines because different sections of the body account for 9% of the skin area. So for example, the front side of your chest, we would consider that 9% of your skin. The back side of your chest, another 9%, or the lower part of your back, 9%, so on and so forth. The genital region accounts for that last 1% once we've added up all other 11 9%. When we're thinking about this rule of nines, not only is it important for us estimating the amount of skin that has been damaged, but it's also a critical tool for us to determine how much fluid a patient might be losing. Because again, remember that in a critical burn, thing number one that we must deal with is that fluid loss. So if I can determine how much of a patient's skin is leaking fluid, I can then estimate how much fluid I should be administering to that patient. So quick recap. We've talked about how we have different kinds of burns, first degree, second degree, third degree, based on how far they go down into the skin. Then we talked about our treatment protocol with these patients. Number one, make sure their fluid is stable. Number two, make sure we're not getting an infection inside their body. And number three, we talked about this rule of nines. This is what we use to figure out how much fluid we need to give to that patient to ensure that they don't go into shock, that they haven't lost too much fluid.